Hi, I'm Mark for ACLS Certification Institute, and I am excited today because we have a special edition extended ACLS mailbox response. And our comment comes today from Roe Campbell 93, and this was off one of our rapid algorithm reviews for tachycardia. And they wrote, amiodarone for stable, wide, complex, monomorphic tachycardia, ? Adenosine is now preferred. Oh, Roe Campbell 93, this is not your fault. You've fallen victim to one of the classic blunders, the most famous of which is never get involved in a land war in Asia. But only slightly less well known is this: never go in against a Sicilian when death is on. So why do we use adenosine to treat VTAC and wide complex tachycardias? We don't. So why would adenosine appear in a VTAC algorithm? Good question. Let's take a look at that. So first of all, what does adenosine do and why do we use adenosine? Now, when administered IV, adenosine causes an interruption at the AV node. It blocks the impulse there. And in reading other articles, they almost describe adenosine as a paralytic for the atrial chambers. So it knocks out the SA node, all the atrial firing, and the AV node. And we use adenosine to help treat supraventricular tachycardias. Again, supraventricular. Supra above, ventricular above the ventricles. So this impulse originated somewhere up in the atrium, or down here, but it was above the ventricles. Now, when the conduction takes its normal pathway through the ventricles, it'll create a normal QRS. That's almost its normal drive to work. And it should create a QRS of no greater or equal than 0.12 seconds. That's a normal QRS. This is where we get into aberrant conductions. And aberrant simply means an unusual, something that occurred unusually, and in this case, an unusual path. That ventricular impulse had to take a detour. Now, when I'm driving to work, there's only one way for me to get from my house to the hospital. And they're constantly working on this road, and they're doing a great job, but every time I have to take a detour or get stopped, or some delay, or they slow the speed limit down, I'm late for work. It's gonna take me longer to get to work every single time. And whether it's a block in the road or a detour, regardless of the detour, it takes me longer to get to work. Now, in an aberrant conduction in the heart, it's the same thing. That conduction had to take a detour, some aberrancy. It had to take a detour, which means it's gonna take longer for that impulse to get through the ventricles. And we know it does because we can measure our QRS. Remember, when you're looking from left to right on an EKG strip, that's a measurement of time. So by measuring the width of the QRS, we can tell, did this impulse have to take a detour somewhere? And it did. Now, we don't know whether it was a block up here or some detour down in the bundle branch, but that ventricular impulse had to take a detour. Now, here's the rub. Sometimes it's difficult to tell the difference between VTAC or a supraventricular tachycardia with a ventricular aberrant conduction. Sometimes you can't tell the difference. For example, here's two strips. One is supraventricular with an aberrant conduction or a detour. The other one is VTAC. So what's the best way to tell whether this is VTAC or SVT with an aberrancy? 12-lead EKG would probably be the best way. And we could use the criteria in a 12-lead to discern whether this is truly ventricular in nature or if it's supraventricular with an aberrancy. Now, ACLS doesn't get a lot into 12-lead interpretation. One, because 12-lead interpretation is a class all by itself. And I highly recommend you go back into your 12-lead books like I have to do and review this material often. You can't look at enough 12 leads and you have to review it. So if you're in the field and you're looking at this and you're going, geez, is this VTAC or is this SVT with an aberrancy, and you don't have time to get a quick 12 lead, what's another thing that we can do to check where's this impulse coming from? You can give them adenosine. And that's why we give the adenosine. The adenosine isn't to treat the VTAC. The adenosine is to discern, is this rhythm truly ventricular in nature, or is it a supraventricular tachycardia with an aberrant ventricular conduction that's making it look wide? If we give him the adenosine and it's supraventricular in nature, it may terminate the tachycardia. Groovy, it was supraventricular. But if it's truly VTAC and we're giving him adenosine, nothing's going to happen. So adenosine is used to treat supraventricular tachycardias. Remember, the impulse has originated somewhere in the atrium, it's come down to the AV node, and then it's moving out through the ventricles. Well, if the adenosine blocks it here, it'll terminate or help slow down that supraventricular tachycardia. That is why we give adenosine in wide complex and VTAC algorithms. Now remember, adenosine should only be administered in regular rhythms. No irregular rhythms, whether it's narrow complex, wide complex, only regular rhythms. And again, a regular rhythm, the R waves are going to march out, equal spacing between the two. Don't use adenosine for irregular arrhythmias. Now, in real life, what's more likely to happen? VTAC or SVT with an aberrancy? Well, they did a study and they counted them up, and more often than not, in a wide complex rhythm, it was really VTAC. So when in doubt, treat for VTAC. Now this brings me to the next thing I wanted to talk to you about. Where did I get this information? If you've gone to an ACLS class, you probably got the provider manual, which is a great textbook. But the provider manual is really a how-to book. How do we do the ACLS? How do we implement it? How do we perform it? The why we're doing what we're doing can be found in the ECC guidelines for BLS and cardiac care. Completely different book. And that book has most of the studies and the why we're doing what we're doing. It was out of that textbook, when you look at how often VTAC occurs versus SVT with aberrancy, clearly VTAC is the more popular arrhythmia. When in doubt, treat for VTAC. I'm Mark for ACLS Certification Institute, and thank you for watching this expanded ACLS mailbox. Remember, like us on Facebook, and please become a subscriber to our YouTube channel. Thanks, I'll see you in the next video.